Dr. Raja sir, will be speaking on when not to touch subretinal fluid.
Good morning, everyone. Thank you to Anirudh for including me in this instruction course. I'll be talking about when not to treat subretinal fluid. It's a trick question, like exam student is there, PG, and examiner will throw questions and things like this. And you have to come up with innovative, various answers. The examiner will keep asking what else, what else, what you have to keep on thinking because it's not related to a particular topic. I think it's not related to ARMD when you don't want to treat. It's a very broad thing which I have put in here. So overall, there are some conditions where we know that it's a well known teaching that in very acute CSR, usually we give time. So you don't have to rush someone who has 5 days history of acute CSR unless there are some specific indications. We know there are some exceptions. We are not going into that. But that is one condition where you actually have subretinal fluid, but you can observe. And I will also be showing later on some conditions where you think it is subretinal fluid, but it's not actually subretinal fluid. But there are conditions like here, there is subretinal fluid, but you can wait for some time in these cases. What about macular degeneration? In macular degeneration, now there is a concept that you look at different compartments of fluid, intraretinal fluid or subretinal fluid or even sub-RPE fluid. So generally sub-RPE fluid, in general we have not been treating, but intraretinal fluid is definitely harmful, subretinal fluid is less harmful, and the fluid study has shown, but we have to take it in the right way. It doesn't say that don't treat subretinal fluid. It says that you can treat and extend. But what in treat and extend means is you are actually injecting every visit. Whether there is SRF or no SRF, there is no option of not treating a patient. You are still injecting, but you are injecting as if there is no fluid. But you don't have to like be aggressive if there is only subretinal fluid and it's less than 200 microns. I'll just show even in the CAT trial and VIEW trial post hoc analysis, it showed that those who have intraretinal fluid, the vision loss is much more. Those who have subretinal fluid, the vision loss is less. In fact, those who did not have SRF probably had slightly less vision compared to those who had SRF. So less than 200 microns you can tolerate, but you are injecting. You are not basically coming back to monthly injections. You can still extend. Another condition where you are not going to be very aggressive or probably you are going to give time is in the immediate post-operative period. For retinal detachment, we know that OCT studies have been done that you do the first day, 1 week, sometimes 1 month, sometimes 6 months. Under the macula you can still have fluid. So you don't have to rush in immediately within a few days to go back to the operating room to redo the surgery. Another condition, mactel, there can be non-neovascular exudation also. They just subretinal fluid kind of pocket. You don't have to treat those conditions. What about dome-shaped maculopathy? There can be SRF. People have tried different ways, X, Y, Z, and overall it may or may not make much of a difference, but be careful if there is any CNVM in these cases. Then you have other diseases, dystrophy. Sometimes you can have best or even adult vitelliform. Sometimes focal choroidal excavation is there, which is non-conforming, and you think that it's SRF due to some pathology. You don't have to treat those conditions. So that was best. Then even adult vitelliform you can have. The other thing which I wanted to convey is what kind of treatment. We are sometimes very keen or eager to give injections in the eye, and that is something we should be very, very mindful about. Even if there is subretinal, some dark space on the OCT, you want to give injection. but be careful about at least the diagnosis, whether it is indicated or not. We have seen many patients of acute CSR also being given intravitreal injections, knowing that it is CSR, knowing that it is SRF. But sometimes there is the other way around also. Sometimes it can be confusing whether there is CNVM or not. This was a patient with acute CSR. Fibrin actually was misdiagnosed as CNVM, got injections. We did an FA and Navilas laser, and this fluid went away. This is another case where, sorry, I'll go back, uh, where a patient had history of trauma, small macular hole. When you are seeing macular holes, in this case we did not do any surgery, but even after surgery of our macular hole, you can have some amount of fluid. It's a course of remodeling over a few months or weeks, that the macular hole, when it closes, there will be a pocket of SRF, so you don't have to worry about that. Sometimes very basic, there is actually no SRF in some conditions, but we may get carried away or mistakenly say that think about SRF. So people have long photoreceptor outer segment tips, and that sometimes, if you look carefully, if you have a very nice OCT, you may mistake it for subretinal fluid. It's not subretinal fluid. The other condition which may mimic subretinal fluid, masquerade. Uh, so there can be many, but if you have any photic injury, welders, laser, solar retinopathy, you can have a loss of the outer segments and it can look like a subretinal fluid. But in a subretinal fluid, there is a surface tension, so it will have a slightly higher center, and on the sides there will be an angle. Whereas in these photic injury, solar retinopathy, it will be a straight box-like lesion. So you can make out whether it's subretinal fluid or not. The other mimicker is outer retinal tubulation. Many of you may have heard about it. This is due to photoreceptor regeneration. There is an inner lining to these, and these are not typical subretinal fluid. You need to be careful. The other condition, sometimes we do not examine clinically. Patient shows one scan, and we say you have to give an injection, but always go back and see what the cause of this fluid is. So this is a case who was sent, who was shown advised injection and came for opinion. What do you think? And I saw there is nothing special that I am able to see for the cause of this fluid. But when I examined carefully, did another OCD, it's actually a macular hole. So overall, these are, as Anirudh was saying, the beginning of my presentation is like an exam, like, what else, what, maybe there will be many else, you may be able to add something, but these are some things which I could think of, and with that I would like to thank you all for your kind attention.
Thank you, sir. Any questions for sir? Sir, I have a question. So we have some patients of chronic CSE where, let's say you have a chronic sub, and let's say if you don't have an OCT angiography, when do you decide when do you decide that there is possibly an underlying CSE and an anti-VEGF can work? Because sometimes even if you have OCT angiography, the membrane may not show clearly, or you may not be sure that there is a membrane. So how do you decide in those cases?
Yeah, very good question. I don't know if one of you has in presentation on pachychoroid, but when you see on the OCT, what Dr. Anirudh is asking, OCT you may not have. Even if you have, it can bowl a googly at you many times. In the sense, you don't understand what it's showing. Is there a CNVM or not? But if you see a RP irregularity, flat irregular PED, then that's a high suspicion for a CNVM. If you don't see that, and an OCT is showing something like a flow signal, you're probably going to take that as a CN with a pinch of salt, probably, or more than that. But a flat irregular PED on a traditional OCT B scan is a very important finding when you should suspect CNV in those cases. And there is fluid. For me, ICG is a must for pachychoroid diseases, but you should definitely suspect CNV in those cases.
Thank you, sir.